A very good morning to all of you. This is Dr. Deepika Keshri, oral and maxillofacial radiologist from Varanasi. I'll be talking about CBCT today. Before I start, I want to thank Dr. Bhuvan Nagpal and organizing committee of POPMA for inviting me for this session. So the topic of today's discussion is diagnostic capabilities of CBCT in maxillofacial pathology. So briefly, we'll discuss what is CBCT, CBCT versus CT, the role of CBCT in maxillofacial pathologies. Cone beam computed tomography or CBCT is a specialized radiographic imaging technique that provides high resolution 3D visualization of the maxillofacial structures with lower radiation exposure compared to conventional CT scans. It is excellent for hard tissue evaluation and it allows precise diagnosis and treatment planning in various dental and maxillofacial conditions. Let's compare 2D and 3D imaging. In case of 2D imaging, as you can see here in this picture, the letters are superimposed over each other, so it is not possible to make out every detail clearly. Whereas in case of 3D imaging, it is like removing a particular pane or slice to examine it clearly and accurately. Before we proceed, let us talk about the different body planes in which we study the CBCT or CT images. So there is this coronal plane or the frontal plane. In this, you can see here. Then next is the axial or the transverse plane. And the last one is the sagittal plane. In this, we go from right to left. Let us have a look at how the images are acquired in CT and CBCT to understand what is the difference between CT and CBCT. As you can see here in this picture, a CT image is acquired in form of a fan-shaped beam that is used in conventional spiral CT. So what happens is that in this, all the images are acquired in axial or the transverse plane and then they are stacked together to form one complete image. So in this case, what happens is that since there are multiple images that are being covered and captured, so the axial image that is covered is the true image, whereas the coronal and the sagittal that are being formed is a reconstructed or false image. Whereas in case of CBCT, this is a volumetric acquisition, so there is just one rotation around the patient's head. So in this case, you can see that all the images that axial, coronal, and sagittal are acquired and they are true images. So it gives a better detail. Now let us understand how image is acquired in CBCT and in CT. So image in CBCT and CT is acquired in the form of voxels. But what is the difference? The difference here is that in case of CBCT, the voxel is isotropic, whereas in CT, the voxel is anisotropic. Now, why do we need to know this? Because everyone has heard about multiplanar reconstruction or multiplanar reformation. So what happens here is that when we are doing a multiplanar reconstruction in CBCT, since here it is in the form of a cube, so you can see that all the planes are equal. So if we reconstruct any image in any other plane, we will get 1:1 ratio of that image. So here accuracy will be better. Whereas in case of CT, you can see that this is anisotropic. So X is equal to Y but not equal to Z. So when we do a reconstruction in XZ or YZ plane, there will be distortion of the image. That is why CBCT is better than CT. We will also understand this with an example. This 35-year-old female patient was referred to us for assessment of a swelling on the palate. She had already undergone CT scan. This is the CT sections of the patient. So here you can see that there is a mass or swelling over the palate, and there is erosion of the maxillary sinus wall and of the alveolar process. But in this, we cannot differentiate whether this lesion is arising from a tooth, that is it of odontogenic origin or it is due to some other cause. For example, the differentials in this case might be a salivary gland tumor or any lesion arising from either the maxillary antrum, or it could be a central lesion also. So then the patient and the doctor was also confused because many people think that it is an abscess and they start doing RCT. Then we did CBCT. Now you can appreciate the better quality images and the better details in this in these sections. So with this CBCT image, we could clearly see that the teeth were normal in outline. That is, we could rule out that it was not due to an odontogenic cause. And we could see the amount of destruction that was present, and it is much clearer than the CT scan. So we concluded that it was likely to be a case of malignancy, and then the patient was referred to higher center for further treatment without wasting time, because as we all know that malignancy progresses very rapidly and it might be life threatening to the patient. So when we compare these images, you can clearly see the difference between these two images. So we get better spatial resolution with CBCT. CBCT has another advantage of giving a lower radiation dose to the patient, because there are different display modes unique to dentomaxillofacial imaging. And also there is rapid scan time, it is more accurate, and there are reduced artifacts with better multiplanar reformation. Now coming to the different clinical applications of CBCT. CBCT is helpful in evaluation of pathologies in orthodontics, TMJ disorders, endodontics, impactions, paranasal sinus disorders, salivary glands, nasal cavity, trauma, and also in implant planning. We will mainly focus on the pathology part of it. So in pathologies, we can assess hard tissue pathologies, and with the radiographic features, we can try to differentiate between if the lesion is cyst or a tumor, if it is benign or malignant. Also differentiate between solid and cystic lesions, or if the lesion is bony like fibroosseous or giant cell granulomas. It is also useful in case of trauma and pre-surgical planning, also for implants. Then for dental pathologies, we can assess different periapical lesions, which we'll see later in the session. Then also for endodontics like root fractures, resorption, and missed canals. Then for accurate localization of impacted teeth and associated pathologies with impactions like dentigerous cyst and KCOT. Periodontal and alveolar bone diseases like bone loss assessment, dehiscence and fenestration for assessment of endoperio lesions in different temporomandibular joint pathologies, also in sinus pathologies, vascular and calcification pathologies, and developmental and syndromic pathologies. Now we'll see these with example of different cases. So here you can see that this is a 19-year-old OPG of a 19-year-old male patient complaining of swelling on left mid-face region. So in this case, we can see that there is an impacted tooth, but we do not know what is the location of the tooth. Here it appears to be located within the left maxillary sinus, and there is a radiolucent lesion which is involving the left maxilla, maxillary alveolar process, maxillary sinus, and also part of the orbit. So the patient was referred for CBCT, and when we did CBCT, so what you can see here in this case that this impacted tooth is located into the posterior part of the left nasal fossa, and it is surrounded by a large hypodense mass lesion with thin sclerotic borders around the lesion, and it is expansile and unilocular in nature. So the differentials in this case would be dentigerous cyst, and also it might be a KCOT. This is a case of multiple dentigerous cysts that was present in this male patient, young male patient. He was 14 years old. As you can see here that this tooth number 18 is associated with this lytic lesion. Similarly, you can see here in relation to tooth number 38 and in relation to tooth number 48. So multiple dentigerous cysts were present. It was actually familial. His mother and his elder brother also had similar kind of lesions. The biopsy report confirmed that it was a case of dentigerous cyst on both the sides. Now, this is another case of a multilocular lesion in relation to right mandible. You can see the amount of expansion and destruction of the cortical plates that you can see, and you can also see the locules over here. And the septae that are present. So it's a multilocular lesion. So also in the axial sections, you can easily appreciate that there is significant expansion of the buccal cortex with perforation of the buccal and the lingual cortical plates. There was significant erosion of the mandibular nerve canal, and also we can see these septae. So the differentials might include either it could be a ameloblastoma or a KCOT. Other possibilities are also there. This was a case of radicular cyst in relation to 2-1 associated with a crack in the tooth secondary to trauma. As we can see here in this case, that there is a very faint crack line in relation to 2-1. Also, the tooth is fractured, and we can also appreciate this radiolucent line. This is a crack line in the tooth. So, and this was associated with a lytic lesion. So, most likely it is to be a radicular cyst. That's how we can differentiate. Now, moving further to a mixed lesion in the left anterior maxilla, you can see like a soap bubble or a no, sorry, honeycomb appearance. It appears to be gelatinous or loose kind of tissue. So when we look at the sections, we can see it's a mixed lesion with very fine internal loculations and appearing to be like a honeycomb-like structure. But here we can see that the outer cortex is thinned out, but it is maintained. So the possibilities in this case include odontogenic myxoma, and the differentiating features include that it has straight septa and intact thin bony cortex. Another possibility is odontogenic fibroma. These can be differentiated only by histopathology. Then we can also consider ameloblastoma, central giant cell granuloma, central or intraosseous hemangioma, although it is rare, and also osteogenic sarcoma. But in osteogenic sarcoma, the bony cortex will not be maintained, and it will also have a spiculated appearance. Next, coming to another case, this 40-year-old female was referred to us, and she was complaining of swelling in the lower right back jaw region for 2 to 3 months. So this, when we went for OPG, we could see that there is a lesion over here. It appears to be slightly radiopaque. However, CBCT was advised. Now, when we did CBCT, we can see that the lesion is not only limited to this part, but there is another part of the lesion which is located posterior. So this is hypodense in appearance, whereas this one appears to be more radiopaque and appears to be more mature, in a more mature stage. So differential diagnosis of ossifying fibroma and ameloblastic fibroma were considered, and the histopathologic features were consistent with that of fibroma. Now, this case was reported by a general pathologist, so that's why only this fibroma diagnosis was given. Oral pathologist can help better in this case. This 20-year-old male patient reported to us for swelling in the right upper jaw region, and we could see that there is a huge hyperdense mass in this case and associated with an impacted tooth. Now, here in this case, what we see here is that there is a very well-defined hyperdense mass, but it is also encapsulated, surrounded by this thin radiolucent capsule. So a diagnosis of ossifying fibroma was considered in this case. Coming to another case where this 10-year-old female patient was complaining of swelling and non-eruption of right upper front teeth. And when we took CBCT, we could see clusters of multiple miniature teeth-like structures in the anterior maxilla region. So this was a case of compound odontome. You can also see these cluster of teeth in the 3D reconstruction images. Next case is a 5-year-old female patient reported to us with swelling and pus discharge from left side of face for 2 months. In these axial sections, we can see that there is expansion of the cortical plates, thickening of the mandibular body, and with few areas of radiolysis. Also, here we can see how the bone is thickened more. It appears to be like a periosteal reaction. This is the 3D image of the same patient. Since the teeth in this case appear to be normal, so a differential of fibrous dysplasia was also considered. However, it came out to be osteomyelitis. Now, this 15-year-old male presented to us with facial asymmetry, and we can see the ground glass appearance present in the right mandibular body and significant expansion and thickening of the mandibular alveolar process. Also, expansion of the cortical plates is seen. So, a diagnosis of fibrous dysplasia was given in this case. This patient, she was 35-year-old, and she was complaining of a non-healing wound after extraction of upper right back teeth. So after taking a detailed history, she told us that she was a known case of tuberculosis. And when we did CBCT, we could see that there was a pathologic fracture here with ill-defined destruction in this case. So actually, she had developed tuberculous osteomyelitis. Now, this patient, he was complaining of occasional pus discharge or fluid discharge from upper front jaw region for 20 years, and he gave a history of undergoing extraction of upper front teeth 10 years back, and also gave a history of trauma in childhood. When we did CBCT, we could see that the incisive canal is widened, circular in shape and in cross section, having a greatest diameter of 9.5 millimeter, and also producing a soft tissue bulge over here. So it was a case of nasopalatine duct cyst. The average size of an incisive canal is less than 6 millimeter, but it was 9 millimeter in this case. This is another case of incisive canal cyst where the incisive canal has significantly widened to about 2 centimeters in greatest diameter. Now, coming to another case, there was a 35-year-old male who was referred to Diagnostic by an ENT surgeon, and he also complained of pain in lower right back jaw region and restricted mouth opening. But patient was advised to go for CBCT of TMJ. So what happened is that when we did CBCT of TMJ, we could see that there was no abnormality associated, but the patient was having symptoms. So what could be the reason why the patient was not able to open his mouth for so long? So we decided to go for a full both jaw CBCT. So in that case, we could see that there is a hypodense mass lesion which is causing destruction of the posterolateral wall of the right maxillary sinus, and it is also causing, as you can see here, a partial compromise of the regional airway in this region. Similar mass, same mass you can see here in these sagittal sections. Also here, it's present over here, as you can see. It's also causing slight erosion over here. So it was considered to be a soft tissue mass, most likely to be a malignancy. So the patient was referred for further management. Now, this 18-year-old female patient complains of swelling in right side of palate for 2 to 3 years. You can see this is the swelling. So on CBCT, we could see that the palate is intact. However, there is slight erosion of the maxillary alveolar process over here. So it appeared to be benign in nature and most likely to be a minor salivary gland tumor. So that radiographic diagnosis was given, and the histopathologic diagnosis came out to be pleomorphic adenoma of minor salivary gland. Now, this 30-year-old female patient was complaining of swelling and bleeding in relation to right posterior mandible for 2.5 years. So in this case, we can see that the right mandibular nerve canal appears to be tortuous and appears to be relatively widened. So when we did CBCT, in CBCT, you can see the widening of the right mandibular nerve canal. So the possibilities include that it might be either a neural or a vascular lesion, which will be confirmed by biopsy. Now, this patient, 20-year-old, she complained of pain in the neck region. So on OPG, we could see that the styloid processes were elongated and the teeth were apparently all normal in outline. So a CBCT of bilateral styloid region was done to assess the length and thickness of the styloid processes. Patient was then, she was admitted to BHU, and then she underwent surgery, and then when she was fine after the surgery. CBCT is also helpful in assessment of orientation of impacted teeth. For example, in this case, the doctor wanted to know what is the orientation of tooth number 35. So in these subsequent sections, we can see that the crown is impinging on the lingual cortex and the root is impinging on the buccal cortex. Also, we can see here in these coronal sections, what is the relationship of the root to the mental foramen. So that's how they can plan for their surgery. Now, also in these 3D images, we can see the orientation of the teeth and the relation of the root to the mental foramen. Now, CBCT is often referred for assessment of the relationship of impacted third molar with mandibular nerve canal. Often, surgeons face difficulty in these cases. So here we can see that the location of the mandibular nerve is lingual to the impacted third molars on either side. And what also here you can see how the crown is oriented and how it is related to the position of the nerve. So then they can accordingly plan how to extract the tooth. Next is a 17-year-old female patient. She complained of pus discharge from right maxilla for 6 months. She gave a history of extraction 6 months back. Now, when you see these sections, we can see that the teeth are missing over here with a bone defect in the right maxillary alveolar process, which is communicating with the right maxillary sinus. And there is a radiolucent lesion within the sinus. And also there is, you can see that there is mucosal thickening over here. So a diagnosis of oroantral fistula with right maxillary antral pseudocyst with associated mild mucosal thickening along the pseudocyst was considered. So like this, we can differentiate whether it's a residual cyst or it might be a antral pseudocyst. Now this patient, she complained of escape of fluid into the nose. This is the oral presentation of the patient. And however, she also showed that she had mucocutaneous lesions like these. So when we did CBCT in these coronal sections, we can see that there is defect in the palate and it is communicating with the nose. Also, you can see here, this is the defect. So it is oronasal communication, likely secondary to either leprosy or mucocutaneous lesion, might be also a deep fungal infection or dermatitis herpetiformis. The next case here, 53-year-old male patient complains of mobile teeth in upper jaw associated with bleeding. He gave a medical history of diabetes mellitus, and also he was giving a history of COVID infection in April 2021. So when we see here, there is very ill-defined kind of destruction in the anterior maxilla and the palate, which is communicating with bilateral maxillary sinuses. And also there is mucosal significant thickening within the sinuses. Now, this kind of appearance, as we can see here also in these coronal sections, this is not like it might be either a osteomyelitis or a deep fungal infection. However, the appearance in this case, we gave a diagnosis of mucormycosis, and the histopathological diagnosis also came out to be mucormycosis. Patient was then treated at KGMC, and then he returned to us after 2 years for another CBCT, and he was fine. And then he also came for planning of zygomatic implants. Now, this patient is 32-year-old male patient, and he was complaining of pain in the right preauricular region for 2 years. He gave a history of trauma and past surgical correction 2 years back. So as you can see here that the external auditory canal, anterior wall of the external auditory canal is fractured, and there is remodeling in the glenoid fossa, in the temporal component of this glenoid fossa, and also in the condyle. So changes of right TMJ arthritis, post-traumatic sequelae with associated bony remodeling could be seen. This patient was complaining of limited mouth opening. Now, when we did CBCT, we can see that there is callus formation over here. It was actually in a case of old fracture, but we can see that there is this space is visible. So it was actually a case of fibrous ankylosis. And there was partial or minimum union with callus formation. Now, this patient, 53-year-old, complained of restricted mouth opening for 14 years. We can see here that there is the contour of the mandibular condyle is irregular in nature, and there is ankylosis of the bone. So it was diagnosed as psoriatic arthritis with bony ankylosis. This 80-year-old male patient complained of pain in left preauricular region. We can see here like the flattening and erosion of the articulating surfaces of the articular eminence and of the mandibular condylar head. Then an osteophyte is also seen. Subchondral pseudocysts are also noted. So actually this is a case of degenerative joint disease. Now coming to another case, now this female patient, 30-year-old, also complained of restricted mouth opening for 8 to 9 months. So when we did CBCT, we could see that there's a huge mass attached to the mandibular condyle with erosion of the articular eminence. Diagnosis of osteochondroma was considered in this case. Now, this is another case of TMJ ankylosis, but in this case, we can also see that there is coronoid hyperplasia. Another case of coronoid hyperplasia you can see here in the section and here. So when the patient goes for corrective surgery, we should not only consider that there is bony ankylosis. So if you will open this and then the patient will be fine. No, we have to also assess this region because this will also create hindrance or blockage when the patient is trying to open the mouth. So complete assessment is required. Similarly, you can see this in the coronal section also. This is the case of multiple tiers of supernumerary and impacted teeth. You can see 1, 2, and 3. 3 tiers in this case. So CBCT would be helpful in how to go about the treatment planning. This is another case of ossifying fibroma we have discussed earlier. You can see a very well-defined hyperdense mass lesion surrounded by an encapsulated, which is encapsulated, and it was present in an 8-year-old female patient. OPG of the same patient. CBCT is also helpful in cases of trauma. Here, this patient sustained multiple trauma like multiple fractures were there. So as you can see that the tooth is fractured over here. There is fracture of the mandibular lower border, also of the right ramus and left subcondylar fracture. This is another case where this patient is having defect in the right maxillary sinus region. We can see that the anterolateral wall of the right maxillary sinus is fractured and displaced inside. This now we have discussed about condylar hyperplasia and coronoid hyperplasia. Now we will discuss about hypoplasia of the mandibular condyle coronoid process and the ramus. You can see this is normal, whereas here you can see the hypoplastic changes in this case. So this was leading to facial asymmetry in the patient. Now coming to the nasal cavity, this 37-year-old male patient was complaining of occasional bleeding from the nose for 5 to 6 months, also complained of post-nasal discharge. When we took this scan, we could see a tooth-like structure within the left nasal fossa. So the CBCT was done for this case, and we could easily locate the position of the tooth, which is displaced within the left nasal fossa, and it is also surrounded by mucosal thickening over here, as you can appreciate in this section. Now, next case is 65-year-old male patient reported to us for swelling on right side of face and with blurring of vision in relation to right eye and fluid discharge from the oral cavity. We can see that there is a huge expansile lesion causing significant destruction of the maxillary alveolar process, right maxillary sinus of the right orbit, and that's why this blurring of vision. So it was considered to be a case of malignancy. Another case of malignancy, patient complained of mobile teeth. On CBCT, you can easily see that there is irregular bony destruction and the teeth are bereft of bone support. Now, this patient, 14-year-old, he complained of gingival swelling and he was also referred for CBCT. Why? Because the surgeon wanted to know what is the thickness of this tissue that is covering the teeth and he wanted to shave it off. So, when we did CBCT, we gave him the amount of what was the thickness of this tissue so that he could proceed with his surgical planning. So, it was a case of gingival hypoplasia. We will briefly discuss about the periopical radiopacities. As you can see here, this is a case of cemento-osseous dysplasia. Here the tooth is normal. This is condensing osteitis. So there is periopical radiopacity and the tooth is carious. Then idiopathic osteosclerosis. Then you can see how hypercementosis looks like. And then what is the appearance of cementoblastoma. So this image will help you in differentiating which periopical lesion is present. So let's compare the CBCT with other modalities. When we see OPG, it is 2D and it is used for screening and it gives limited detail. CT it has excellent soft tissue detail, but there is very high dose and also lesser accuracy as compared to CBCT. MRI is best for soft tissues used for disc and nerves. CBCT is best for hard tissues, especially for the maxillofacial structures, and it has a lower radiation dose. Conclusion: CBCT is an emerging CT technology which has potential applications for imaging of high contrast structures in the head and neck region. Its advantage of MPR and 3D reconstruction enables us not only to diagnose or assess the pathology precisely, but also plan the treatment more effectively. Thank you. Thank you so much.